Hello, my name is Chen. I am currently a radiology trainee at St Vincent's Hospital in Sydney, and I was previously a nuclear medicine trainee at Royal North Shore Hospital, also in Sydney. Thank you for coming to my talk. It is on the utility of reprojected planar images derived from Lu177 Octreotate SPECT data, and specifically, is it a suitable alternative to traditional planar imaging in peptide receptor radionuclide therapy? Lutetium or dodoctreotate therapy, or lutate therapy, has been a common therapeutic option for the treatment for disseminated neuroendocrine tumors, or NETs. Planar whole body imaging is normally done post-treatment to confirm lutate distribution and uptake, in addition to prognostication. Unfortunately, with the whole body planar imaging, there are multiple limitations, specifically in that it has long acquisition times of greater than half an hour for each patient, in addition to a significant difficulty in identifying multiple lesions if there are overlap on the planar images. Specifically, the aims were to compare the 2D and 3D reconstruction algorithms to assess post-treatment lutate uptake. On the left, we can see that a set of true planar images, an anterior and a posterior. And on the right, we have the reconstructed images from the SPECT data. These images were truncated to the knees, but they are normally done as part of the clinical work process. The population for this study were 30 patients with neuroendocrine tumors who have undergone at least one cycle of lutetium octreotate therapy, who had the planar and the SPECT CT images done as per protocol after their cycle of lutate treatment. The SPECT images were then further processed and then planar images were reconstructed from the SPECT data. And the algorithm that was applied was the forward projection technique using MIM software. The scan interpretation was done as a combined read, and the readers were blinded and the patients were interpreted in a random order. There were 2 experienced nuclear medicine physicians who performed the read, and disease localization, specifically the number of lesions in each body area, were then recorded. Specifically, the areas in the body of interest were the liver, the upper abdomen, the thorax, bony disease, as well as head and neck deposits. 3 reads for each patient were done overall, including the true planar images, the reconstructed planar images, and then the 3 sets of images as a whole. That is the true planar images, the reprojected images, as well as the SPECT CT data. This was done to identify concordant and discordant lesions, in addition to using SPECT CT data as the gold standard for disease localization. Overall, unfortunately, one patient's imaging was limited by significant artifact and therefore was removed from the study pool. Of the 29 remaining patients, 383 lesions were identified on the true planar and 343 lesions identified on the reprojected. These were all the differences were all statistically insignificant for the liver, the thorax, the bone, and the head and neck. The upper abdomen difference was statistically significant with a p-value of 0.033, and I will get into why in a little while. The 40 lesion discrepancy overall can be seen on the table below, where 76 lesions were identified on the true planar and 36 on the reprojected. The majority of these were hepatic or abdominopelvic lesions. As mentioned previously, there was no statistically significant difference between the 2 sets of planar images. And therefore, the reprojected images do provide similar information for disease localization for the areas mentioned previously. The abdominopelvic soft tissue disease was the only statistically significant difference, and the discrepancy is largely due to the incorrect localization of a hepatic lesion to an adjacent structure. I'll provide examples in a second. Correlation with the SPECT CT data was performed for accurate assessment and was done as the gold standard. There were some lesions that were identified on SPECT CT data only, and so therefore it is not possible to accurately localize on planar imaging alone, regardless of whether it was true or reprojected data only. The reprojection algorithm had some limitations, particularly that of lower spatial resolution due to the smearing effect as a result of the algorithm reconstruction. And it was difficult to delineate discrete lesions, especially those in close proximity to one another or confluent lesions. The two nuclear medicine physicians did note that the hepatic dome and edges of large lesions were most affected. And as mentioned previously, the planar images clinically always correlated with the SPECT CT images as a gold standard. Planar image use is mostly for the gross assessment, which would be further accurately assessed on SPECT CT data. For example, on the left one, on the left side, we have a true planar images, and on the right, we have reconstructed planar images for the same patient. Here we can see quite a large confluent lesion in the upper right liver in segments 7 and 8. However, you can see it is a bit lobulated on the posterior image. It was not possible to identify discrete lesions within this confluent lesion. This patient also has a similar issue in disease localization of the liver. Here we can see quite a lobulated pattern of uptake within the right lobe of liver, this time convincing that there is more than one lesion. However, it is impossible to specifically count the number of lesions on the true planar imagings, and therefore correlation with SPECT CT images would be the gold standard here. This image also demonstrates this smearing effect, where the lesions on the true planar were slightly sharper and had a higher spatial resolution than that of the reconstructed data. Here we can see the reconstructed data edges a bit more fuzzy and smeared out. Therefore, based on these images, we conclude that the true planar and the planar-like images provide similar information for the interpretation of images for lutetium uptake and prognostication in a clinical context. Spatial image resolution does differ on the reprojected data. However, there was no significant difference for the majority for disease localization. Ultimately, though, correlation with SPECT CT is the gold standard. Here we have an example of the difficulty assessing specific lesions, as well as erroneous disease localization, specifically of the liver and upper abdominal lesions. Here, there is a possibility that there is some subtle lutetium avidity within segment 6 of the liver on the anterior images, which is not well demonstrated on the posterior images. Both the true planar and the reprojected planar provide similar information. Correlation with the SPECT CT data is obviously the best here again. And even on the SPECT CT data, the segment 6 hepatic lesion is subtle, but it is present. And thus concludes my talk on the utility of reprojected planar images and it as a suitable alternative to traditional planar images in the context of peptide receptor radionuclide therapy. Going forward, we hope to use these reconstructed data for further applications, for example, in the assessment of iodine uptake, in whole body planar images for radioablative iodine patients, or other theranostic applications. Thank you very much.